Hi, my name is David Horn. I'm an assistant professor in the Division of Pulmonary and Critical Care Medicine here at the U. On behalf of the Furlan Northwest TB Center, I'm pleased to introduce Dr. Philip LoBue, who is the director of the Division of Tuberculosis Elimination at the U.S. Centers for Disease Control and Prevention. Phil earned his undergraduate and medical degrees at the University of Pennsylvania and went on to complete internal medicine residency and pulmonary and critical care training at the University of California, San Diego, where he was also an assistant clinical professor of medicine. His career at the CDC started in 1999, and between 2006 and 2014, Dr. LoBue was the associate director for the division of tuberculosis for science for the Division of Tuberculosis Elimination before assuming directorship this past year. So, without further ado.
Good morning. Thank you very much for the invitation. It's a real honor and pleasure to be here this morning. And I'm going to talk about what our approach and our thoughts about the way to potentially eliminate TB in the United States, which is really quite a major undertaking when I go through and explain some of the major challenges, especially since you really can't look at TB in isolation in any country. It's a global problem, and what happens in the world really impacts what happens in the U.S. with regard to TB. So let's start by looking at the global problem. There are 9 million new TB cases per year in the world. And in 2013, which is the last year that they had put out data for this, we'll shortly see the 2014 data, but there are also 1.5 million deaths. 1.1 million cases occurred in people who were HIV infected, and there were almost 500,000 cases of multi-drug resistant tuberculosis. And multi-drug resistant tuberculosis is tuberculosis that's resistant to the two best first-line drugs, which are isoniazid and rifampin. The outcomes are worse if you have this form of tuberculosis. It's quite expensive because the drugs are very expensive, and the treatment has to be extended from 6 months, which is our typical course of treatment, to 18 to 24 months. And these cases are occurring in parts of the world where they really cannot afford those drugs or the infrastructure which is needed to deal with that type of problem. So this map shows estimated TB incidence rates, and these are number of new cases per 100,000 population for countries across the globe. And one of the things I'll start out by pointing out is that it's estimated. So unlike the United States and most of the industrialized world where we count individualized cases, the reporting systems and surveillance systems are such that they really don't even know for sure how many cases they have. But these are estimates that have been made frequently with the technical assistance of WHO by doing surveys of various parts of the country. But as you go through, you can see there's quite an unequal distribution in terms of case rates. So we move from the kind of light gray color that are the lowest incidence countries such as the US, Western Europe, Australia. You then start moving to the lighter green and the darker green in Asia, northern parts of Africa. And then finally you get into the dark green colors, which you see in sub-Saharan Africa. And there you have case rates which in some countries are greater than 500 per 100,000. But in terms of the burden, you have to also remember the underlying population. So if you look at a country like India, which is not in the highest case rate category, their case rates on the order somewhere between 150, 200 per 100,000, but they have a huge population. So each year, India contributes about 2 million new TB cases. The concept of tuberculosis elimination goes back a number of decades. And in 1989, the CDC put forward a strategy and plan for eliminating tuberculosis. And they started with a definition the definition of elimination is if there is less than 1 new case per million population, so that would be 0.1 cases per 100,000. And the concept was based on fairly old modeling, which suggested that when you reach this rate the disease really wouldn't be sustainable, and you really wouldn't have to worry so much about it from a public health standpoint. And that definition has remained in place and has been taken up by the World Health Organization, and so we still use it. Now, that, as you see, less than 0.1 cases per 100,000, but where are we now globally? We're at 126 cases per 100,000, so, or 1,260 per million, so there's quite a way to go. In the most recent strategy that WHO put forth, they set some interim targets for 2025 and 2035, which would be 55 cases per 100,000 and 10 cases per 100,000, and those are respectively a 50% and 90% reduction in incidence of TB, and those are really quite ambitious targets. And this graph illustrates how they think theoretically you would get there. So if we start and look at where we are with the current incidence rate, which is over about 125 per 100,000, at the current rate of decline, which is about 2% per year, even at all the way out to 2035, you're still somewhere around 70 per 100,000. So if things just continue as they are, they're not going to get close to their targets. What they think is possible is if we were to optimize every tool that we had in the arsenal against TB, you would be able to achieve a 10% per year reduction. And then at some point, with all the research that's ongoing, there'd be new tools such as new vaccines, some new drugs for prevention, and then you could really accelerate that decline, and that's how you would get there. But I think people who might be a little more cynical think about this cartoon. And this is probably a cartoon many of you have seen before, which is you have some scientists with an equation on one side and then the other side, and then how do you get from one side to the other? Well, then a miracle occurs. Because, for one thing, this change of 10% per year has really only been achieved once, and that it happened in post-World War II Europe. And I think there were many factors that go beyond TB control that affected that. You had, a continent which was really had been the infrastructure had been destroyed. There was terrible malnutrition, and there were great economic and social improvements that probably contributed a lot to the reduction in TB. And then, in terms of these new tools, people have been working on a TB vaccine since Robert Koch showed that the TB bacillus causes tuberculosis back in 1882, and there hasn't, frankly, been a lot of great progress in developing a vaccine. So there are really some really amazing things would probably have to happen for these goals to be reached. So let's move on and talk about what's the current state of tuberculosis in the United States. So here I show a table with different countries and what their incidence rates are. So starting at a country that really has a tremendously high burden, South Africa, they have a case rate of 860 per 100,000. India, about 171. China, 70. Mexico, 25. United Kingdom, 8. And we at the United States, a low-incidence country, are down at a case rate of 3 per 100,000. So you can see there's huge variability across the globe in terms of case rates. And as I mentioned before, there's the issue of also underlying population when you think about burden. So even though India's rate is substantially lower than South Africa, and China's is also, these countries have huge populations. So when you translate the rates and apply them to the populations, they have India about 2 billion cases and China almost 1 million. So those two countries alone contribute about a third of the cases of global TB. And what have been the trends in the United States? So this graph shows the number of TB cases in the U.S. and then year on the x-axis. And were I to take this graph back to 1953, which is the first year where the U.S. began systematically counting cases for TB, there were just under 90,000 cases at that point. There was a steady decline over the next 30 years to the 1980s when we reached a plateau in case counts in the low 20,000s. And then toward the latter 1980s, early 1990s, we actually had a resurgence of TB in the United States. The things that happened at that time, number one, HIV infection was a major contributor. We had more immigration from countries with high burdens of TB. And we also had a pretty substantial deterioration of a lot of the public health infrastructure and TB programs because people looked at TB as a disease of the past and felt we really didn't need to worry about it so much. And the result of that kind of perfect storm was a resurgence. And TB cases peaked in 1992 at, I think, about 27,000. There were major investments at all levels of government, federal, state, local. And since that time, we've implemented, I think, some pretty sound strategies. And we've had pretty much continuous reduction for more than 20 years, to the point that now we, in 2014, had 9,421 TB cases in the U.S., which is the lowest we've ever had. But I would also point out that if elimination is a case rate of less than 1 per million, for the whole country, we would only have 300 TB cases. So there's still quite a gap between 9,400 and 300. And this just shows the actual individual numbers from 2009 to 2014. Again, case rates dropped from just under 4 to 3, and cases from about 11,500 to 9,400, but still pretty far from elimination, which would be a total number of cases about 300. The other thing that's really important to understand about TB is, just as it's not distributed equally over the globe, in the United States it's not equally distributed among the population. So we have some really key risk groups, and the number one risk group are people who have been born outside the United States. 67% of TB cases occur in people who are born outside the U.S. That case rate is about 11 times higher than for people born in the United States. And in terms of countries where these people come from, Mexico, Philippines, Vietnam, China, and India are the top 5. Racial and ethnic minorities account for 85% of the cases. HIV infection is important. It's not what you see in places like sub-Saharan Africa, where you may see that 60 to 80% of people with TB have HIV. In the United States, it's about 6 to 8% from year to year. Homelessness is another important subgroup, about 6% of cases. And then incarceration and substance abuse. And for those last three factors, when we are asked at CDC to go to a local jurisdiction where there's a TB outbreak, just about always one of these three factors is involved, and frequently is an overlap of all three, with people who are homeless, people who have been incarcerated, and people who have had issues with substance abuse. What are the main challenges now in us getting to that goal of elimination? I think there are 5 main challenges. The first one is political commitment, and this was an issue when we had the resurgence in the late 80s and early 90s, which is when cases start to get low, it's less of a priority to the general public, it's less of a priority to policymakers, and so people don't think you need to put the resources into it. And so that's a problem. One thing is, if you have fewer and fewer cases of a disease, there are fewer and fewer doctors, nurses, healthcare, other types of healthcare workers, public health workers who have had experience in dealing with TB. So we have a loss of expertise and experience. Another problem that we have had, despite the great medical technology and access we have to various state-of-the-art drugs, is that we have actually had drug and biological shortages related to TB because we don't have a market. When there are only 9,400 persons with TB, there's not a great incentive for drug companies to make drugs. And so there are 9 of the 15 drugs, there's only a single manufacturer, and when that manufacturer goes down, we don't have drug for that patient. So that's been an issue. Then we have concentration of the remaining cases in some of these populations, which are more difficult to work with. If you have an outbreak that occurs in homeless persons, worrying about TB prevention is not their highest priority. They are concerned about where they're going to sleep and where they're going to get their next meal. And then the next issue is latent tuberculosis. And I'll talk more about this, but the 10,000 cases are coming from a pool of up to 13 million people in the U.S. who have what we call latent tuberculosis. and later that latent tuberculosis reactivates and they become ill with disease. And so it's really this much bigger population that you can potentially prevent from getting TB, but it's a big challenge to reach those people and get them tested and on treatment. So what are the strategies that we look at? So for those of you who may not be familiar with TB, it is an infectious disease. It is transmitted from person to person, and if you have a person with pulmonary TB, they cough, they produce droplet nuclei containing the bacilli. If you're in proximity and inhale air with those bacilli, you can become infected. What happens after that? So if we start with people who are exposed, you are in the room, you breathe that air, there are TB bacilli. The interesting thing is, even in households where you've got people, a person with infectious TB living in a household for months with family members, etc., it turns out that less than 30% of people will become infected, and that is a pretty consistent number and one that's not easily explainable. If someone becomes infected, one of two things happens. A small percentage of people rapidly progress and become sick. We call that progressive primary TB. But most people, their immune system is able to control that infection, contain it, and they go into what we call a state of latent tuberculosis infection. And overall, people who are infected, about 5 to 10% of them will ultimately develop TB disease, and then if they do develop TB disease and they have pulmonary TB, coughing, they then expose more people, and the cycle starts all over again. The way that we find that someone has latent tuberculosis infection is either through a tuberculin skin test or a blood test. Interferon gamma release assays can detect an immune response, and that is how we determine whether someone's got latent infection or not. TB disease can affect any part of the body. Pulmonary case about 80%, and typically you have abnormal x-rays with upper lobe disease cavities. And then you obtain sputum samples and can stain those to see bacilli, but ultimately culture and nucleic acid amplification techniques can detect the organisms to diagnose TB disease. So understanding this pathogenesis helps us understand what we can do to control and prevent and eliminate TB. So if you start with someone who's got infectious TB disease, there are two things we can do. One is we can isolate them so they're not exposing other people. And equally importantly, we get them on treatment. Not only is that treatment going to benefit the patient, because TB is about 95% curable, but pretty quickly, if you have them on the right drug regimen, you reduce that organism burden, and they rapidly, their infectiousness decreases. So that is really the really first key step in TB control and elimination. Now, something else that we can do is for people who are exposed and are at really high risk, so people who have severe immune compromise, HIV infected, or very young children, we can actually give them a medicine, isoniazid, which we call window prophylaxis, to try to prevent this infection from occurring. And then lastly, once you have people who you find that are infected by testing them with tuberculin skin test or interferon gamma release assays, there are several regimens that you can give to treat them to prevent them from progressing to TB disease. So now I'm going to move on and talk a little bit about what modeling might tell us about the approach to TB elimination. And the old joke about modeling that all models are wrong, but some are useful. And I think what, to me, my interpretation of that is that don't look at models as absolute predictors. They do not predict the absolute future, but they can help guide you in making decisions, because by looking at potentially what the impact of interventions might be, it may help guide you on your approach and strategies. So this is a model that was developed at CDC, and so I'm going to walk you through a couple of slides on this to explain how it has influenced our thinking about the approach to elimination. So the black dots represent actual data. And in this model, they divide the populations into the entire U.S. population, which is all foreign-born persons and U.S.-born persons. But I'm going to focus on the all because elimination is defined by 1 case per million in the entire population. So start with the all U.S. persons, and so here's the data, and then when you feed the data that we have into this model, the baseline case, which is we're doing everything that we do now and nothing really changes. What you see is here on the y-axis we have the incidence per million, and we're interested in getting down to 1 because that's our target for elimination. And then this is the years out into time. And so we start with our base case for the whole population. We just do things as we're doing right now. Basically, we get some improvement, but things kind of level off somewhere around a case rate of 20 per million. So we're still pretty far away. The dashed line represents what would happen if we could double the amount of treatment of latent tuberculosis in the U.S. And that pushes us down a little further. Maybe now we're getting around 10. And then this dot dash line represents what would happen if we could quadruple the amount of latent tuberculosis treatment in the United States. And that pushes it down a little further, and we're now around 5, which is not bad, but we're still not near 1. So the other thing that the modelers looked at was an assumption such as WHO is targeting, which is you really decrease global TB, so we have less TB coming into the United States. And so what would happen if you could really drive down global TB and you could decrease the importation of latent tuberculosis among foreign-born persons entering the United States? And so this graph is set up the same way. We have our incidence per million per year. Again, targets down here at 1, years of time. Blue rectangle, we're focusing on the entire U.S. population with the same 3 lines, which is, okay, we've reduced the amount of importation, but we're not doing anything else really. Gets lower, down to 5. Double LTBI treatment gets even lower. Maybe we're getting around 3. And if we could quadruple LTBI treatment and do this, we're starting to get down, not quite there, but we're getting close to 1. So while, again, a model is not going to be something that predicts the future, what I think we have taken away from this is there are 2 key things that we need to think about. One is you have to address TB in foreign-born persons as a key focus population, and really this is going to require both domestic strategies and global strategies, because just working on dealing with TB in the U.S. is not enough. And then we have to do a better job with latent tuberculosis infection. So there's been, like with many diseases or areas where you really are focused on a goal, there's been a lot of different plans and strategies that have followed from the 1989 plan. And I'm going to talk a bit about one that was produced in 2000 by the Institute of Medicine. And even though this is 15 years old, what is in this report, I think still the 6 elements that they outlined as key to TB elimination are still relevant. Now, technologies have changed and some of our approaches have changed, so we may do things a little differently, but the fundamentals that were in this report remain true even 15 years later. So I'm going to talk about what are these elements and what are the kind of things that we need to think about as we approach them. So there were 6 goals laid out in this report and in the response from the various federal agencies to the report. And the first one may seem kind of obvious, but can't be neglected, which is you have to maintain your control activities in place, because if you start just solely focusing on latent tuberculosis infection and forget about everything else, it actually isn't going to work. And things will. And if you look at the models, when you start having worse outcomes with people with TB disease, it really makes things a lot worse. So you cannot forget about the basics of maintaining control. And what the basics are is you have to diagnose people as quickly as possible so that they're not infectious for long periods and spreading the disease. You need to get them on the right treatment as soon as possible. You need to do contact investigations, because the people who are those are the people who are exposed. If you're in the household with a TB patient, you're exposed. Find those people. There'll be about 1% of them will probably have TB disease. And then I'll talk a little bit. There are also people who are particularly risk for latent TB and progression. And then the other things are basic infection control measures. So if we break these down a bit, first, complete and rapid detection. In the U.S., pretty much we find everyone with TB. Occasionally, unfortunately, there are people who are found at autopsy, and that's not good. But most of the time, we find them, and we can get them on treatment. The problem is sometimes there are substantial delays. And anyone who's worked in TB control will tell you the story of the person who was from the Philippines and went to the emergency room 3 times with a cough that had been there for quite a while, and they'd gotten 3 different courses of antibiotics, and no one ever considered TB. And then finally, someone says, oh, after 3 months, this person's not getting any better, we need to do a chest x-ray, and they have bilateral upper lobe disease and multiple cavities. And this gets back to part of the issue of people not having experience in dealing with TB or not even thinking about it because it's not that common anymore. And those delays lead to more transmission. We do have some tests. 20 years ago, it might have been more of a problem also with our technologies because we were dependent on solid culture tests, which could take many weeks to detect the organism. But now we have genetic tests, which are pretty rapid. And so technology is pretty decent. But it's really more of an issue of having providers think about the possibility of TB. It doesn't matter how good the tests are if you don't order them. So that's one challenge and one thing which is not, we don't have a really easy solution to. The thing that we do have that works very well is we have very high completion rates in the U.S. And that, as I said before, not only benefits individuals, but it prevents the community because you get people treated and cured, they are not spreading TB. And we do well with the current regimen, but the current regimen requires 6 months, 4 drugs for 2 months, and then 2 drugs for 4 months. It's not that easy. And we also do it under something called directly observed therapy because we need to make sure people finish that regimen. So we have either healthcare workers going out to people's houses or places of work and actually making sure, watching them take the medication, or sometimes they come to clinic and take the medication. That's incredibly resource intensive. You think about what that involves. So it works incredibly well, but it is resource intensive. So anything that can be done to shorten that regimen would be really helpful, especially related to cost issues. Contact investigation is really important because for 2 reasons. One, when you do a contact investigation, overall we find that you'll find 1 to 2% of the contacts you will find active TB disease in those contacts. So you will find additional cases. The second thing is you will find LTBI. And as I mentioned, up to 30% of the household contacts will be infected. And it turns out that if you're recently infected, your risk for progression is higher. So your biggest risk for progression is within the first 2 years of infection. So this is a particularly important group. And those contacts should be evaluated for TB disease. They should also be tested for LTBI with either a skin test or an interferon gamma release assay. And then we have a number of treatment regimens for LTBI that can be used to prevent them from progressing disease. The oldest one is isoniazid. That takes 9 months, and completion rates are not great with that, but we have some more recent regimens, 3 months of isoniazid and rifapentine and 4 months of rifampin, which are other alternatives, which are well tolerated and have higher completion rates. So these are some things that I think are promising. And lastly, with regard to this goal is infection control measures are really important. One of the issues that happened in the 1990s was we had transmission occurring in healthcare facilities. In New York City, San Francisco, Florida, there was MDR TB transmission occurring in hospitals, which is really unacceptable. We still see this. Fortunately, we don't really see this in healthcare facilities so much anymore, but we do see it in homeless shelters still. Even in Atlanta, we've had a large outbreak over the last several years with over 100 cases of TB that have been transmitted within homeless shelters. And we see it in correctional facilities. The approach, it's a hierarchy, a 3-tiered approach. The first is administrative. You need to have an infection control plan. All of you are probably familiar that you're getting tested annually if you're dealing with TB patients, or in a place that has TB patients, you get skin tested or quantiferon or T-spot annually. And the other important thing, just as it relates to any TB patient, is if someone comes into your emergency room and they have TB, you need to think about that and get them in isolation. You don't want them in an ICU with undiagnosed TB. You don't want them spreading TB within the hospital. So And then engineering controls, we have special rooms with negative pressure, frequent air changes. And then the final approach is personal respiratory protection, which is basically wearing respirators. So that's how we deal with infection control. Goal 2 of the IOM report is accelerate the decline. And the underlying categories here are, 1, as I mentioned, focusing on targeting people who are at high risk for TB, to test them for latent TB and treat them. Some of this thoughts even back then, because cases were going down, do we need to regionalize some of our services because it's not feasible for some states with just a few TB cases to do everything related to TB. But another issue is recognizing outbreaks quickly and intervening and making sure that you get them under control and basically eliminate the outbreaks. And so there are a number of tools that we now have with our ability to fingerprint or genotype isolates that can tell us whether it looks like there's recent transmission occurring. So under the issue of targeted testing, as I mentioned, we test with either a skin test or IGRA. I mentioned the regimens that we use. But the key thing here is you need to target populations at risk. We do not want to test the entire United States. You test low-risk populations, you get lots of false positives. The tuberculin skin test and even the IGRA blood test are not the greatest tests in the world, and if you test low-risk populations, you will get lots of false positives. So you need to focus on people who are at risk, and the biggest population that contributes to TB case in the U.S. are people who were born or lived for long periods of time in countries with medium or high rates of TB. So that's really a major focus. HIV-infected persons are really at high risk for progression. Other immunosuppressed or other immunocompromising conditions or drugs, and then homeless, correctional facilities, and people who abuse substances. These are really populations that we're concerned about. In terms of regionalization, as I mentioned, it just may not be feasible when you get down to a small number of cases to have the whole array of TB services available and have the expertise. So we have started doing some things, looking at some regional approaches. One is we have developed regional training and medical consultation centers. We have 5 across the United States, and they have TB experts available to answer clinicians' questions and help them manage cases. They also do training for staff. We've recently put together a laboratory center for excellence for drug susceptibility testing, because there are certain states that if you have, we feel that, and most laboratorians feel that if you have less than 50, if you do less than 50 drug susceptibility tests per year, you're probably not able to maintain proficiency and do those tests well. So now we have a number of states that are on board with this, and they're sending their samples to this laboratory, which has the expertise and does a lot of this testing, which is the California laboratory, so that we provide this service, and it removes the need to have drug susceptibility testing at every state lab when they really can't maintain proficiency. And then finally, genotyping. So we have, and that's nationalized. So basically, we've made it available to the entire country through a contract with the Public Health Laboratory in Michigan, that any isolate from a patient can be sent to that lab and get genotyped, and that's been really useful when it comes to the next issue, which is dealing with outbreaks and interrupting transmission. Because the first thing you have to do is recognize that there's an outbreak. And if you have populations where there's just a lot of TB and you see a lot of TB cases, you don't know whether that's recent transmission or not. So how do you look at that? Well, you look at the isolate, you get the culture of the bug from them, and you genotype it and see whether those are genetically the same. So, if I have a group of people down here and they all have TB, and we get the cultures from them and we look at the genetic composition and it's all different, that's not recent transmission. They didn't transmit it to each other. They probably got it from somewhere else, and now they just had LTBI and they've reactivated. However, if they all match, that's of a concern, and it suggests that there's probably transmission going on here, and you have to be worried that you have an outbreak. Because we've offered this service nationally, we actually have 94% coverage. So we have genotypes on 94% of all culture-positive TB case in the United States, and we can actually look at this nationally. And so we have developed algorithms where we can actually potentially recognize outbreaks from Atlanta and look at things that states may not be able to do, which is look across state lines, because these things may not be concentrated, within a political organization. TB can cross state lines, and the state may not be able to see that. So I think we've had the new ability to recognize outbreaks, but then the next thing you have to do is you have to be able to respond. And response is resource intensive because you have to do a few things. One is you have to really do more intensive active case finding. So if you have an outbreak among homeless people, it means you may have to go into homeless shelters and do really intensive interviews, or sometimes go in and do x-rays among the whole facility to do active case finding. The next thing is you have to do a more intensive contact investigation, because if you're having transmission and you haven't recognized it, you're probably missing contact. So you have to relook at that. And then in some cases, because in some of these facilities, it's because they don't have appropriate infection control measures. So that may need to be addressed. Goal 3 is develop new tools, and that's really about research. So, you look at some of the tools that we use in TB, and they're pretty old. I mean, the tuberculin skin test is 100 years old, over 100 years. Even interferon gamma release assays now are over 20 years old, and the drug regimens that we're using, these drugs, isoniazid goes back to the 1950s, rifampin, late 60s, early 70s. So there hasn't been, we still use some old tools. So we could really use some new tools because, as I've mentioned, the things that I talk about are really resource intensive. We need shorter regimens, for example. So what do we really need? Well, I think in terms of diagnosis of people with TB disease, we've made a lot of progress, basically through the various types of genetic tests, PCR-based tests that we have available. So we can pretty rapidly diagnose people. It could always be a little better. The one thing about nucleic acid amplification tests in TB, if you compare them, for example, to those used in sexually transmitted diseases, and some of the STDs, those tests are like 100%, pretty close to 100% sensitive. In TB, they're only about 75 to 85% sensitive compared to culture. So we still have a little room for improvement. And the issue with culture is that even though we use liquid cultures, which are faster, they can still take on average about 2 weeks to get a positive result. So it can still lead to delays in diagnosis. And the old rapid test, another one which has been around for over 100 years, which is the AFB smear, where you just take a sputum sample and look under a microscope, that only detects about half of the cases, so it's not that sensitive. So there's a little room for improvement here. Where there's room for a lot of improvement are tests that are much better at finding people with LTBI and predicting those who will progress. So right now, if you have a positive skin test or even a positive blood test, at maximum, there's probably about a 10% chance that you would progress to TB, which means, and it may be 5% or lower. So that means that when we're going out and testing people and treating them, we have to treat 10 to 20 people for every person who would get TB. That's not very efficient. And so it would really be nice if we had a test that was much better at predicting of those who are infected, who is more likely to go on. And that's kind of a dream. There's really not a lot of progress in that area. Shorter course regimens for both TB disease and LTBI. This is, if you go back to the original regimens for TB, those were 2 years or more. And we've got, for drug-susceptible TB, we've gotten it down to about 6 months, but that's still a lot of work. It'd be nice if they were 2 or 3 months or even less. And LTBI, similarly, 9 months is a long time for people to take medicines who are not sick. People with LTBI are infected, but they're not sick. So convincing them to take 9 months of isoniazid is a tough task. It's better when we can cut it to 3 months, but all of you have dealt with just having people take a course of, 5 or 10 days of antibiotics, and there are plenty of people who just stop taking the medicine when they feel better. So this is a real challenge. It would be nice, if we could really get down to really short regimens that were a few weeks or less. Drug-resistant TB, in the U.S., we only have about 100 cases of MDR, but they are challenging and expensive. And this is an area where we really need some new drugs. And then ultimately, what infectious disease has been eradicated? Smallpox. How did they eradicate smallpox? They had a vaccine. Polio, which is getting close, has a vaccine. Probably, and you saw that in the earlier slide I showed from WHO, a vaccine is probably a critical tool to ultimately, certainly for global TB elimination. But that has been something that people have been working on for 100 years, and we unfortunately haven't had a lot of progress with that either. So goal 4 is about reducing the global burden of TB, because the modeling, as I've shown, and if you look at the epidemiology, suggests that if we don't have improvements in global TB, it's going to be really, really difficult just to eliminate TB in the United States. So at CDC and throughout the U.S. government, U.S. Agency for International Development, NIH, FDA, there's a great interest in assisting other countries and multilaterals in trying to do that. And so the approach has been, number one, we support global organizations such as the World Health Organization in developing global policy and really bringing together the best evidence-based policy and trying to get that implemented as much as possible, but also to work with individual countries in a strategic way to try to help them improve their TB control and elimination efforts. Some of the big obstacles here are drug resistance and HIV. As I showed you, HIV, we only have about 7% of the people in the U.S. who are infected with HIV. If you go to Botswana, it's probably 60%. Much, much bigger challenge. And then in terms of multi-drug resistant TB, we only have 100 cases in the United States, but there are 500,000 globally. And most of these countries, when you're talking about so if we look at the cost of treating cases in the U.S., for a case of drug-susceptible TB, it's about $17,000 on average. If you move to MDR, it's about $150,000. If you move to extensively drug-resistant TB, which is MDR plus resistance to some of the second-line drugs, now you're moving into about $400,000. It's hard enough for us to afford that in the United States. It's almost impossible in many other places in the world. So these are really, really major obstacles. The other thing that we work on with our partner division at CDC, which is the Division of Global Migration and Quarantine, is that there are screening programs that occur for some people who come to the U.S. So if you're coming as a permanent immigrant, then you must go through a TB screening, or if you are a refugee, they have a screening program in place. And these programs are quite effective. They use all state-of-the-art diagnosis and treatment. And so not only is it benefiting us in the U.S., because people are getting diagnosed and treated before they come here, but it's benefiting those individuals because in many places they wouldn't have access to this type of care. And while that's been helpful, most cases of TB in the United States that we see in foreign-born persons is actually reactivation of latent tuberculosis infection, and sometimes it's years or decades after that infection occurred. So someone might have been infected in the Philippines. They are not sick with TB. They have latent infection. They come to the U.S. They live in the U.S. for 10 years, and then for some reason their TB reactivates and they have active TB. And so the screening programs that we have won't be able to address that. So that's, can we look at potentially addressing latent TB in these populations? And then the current program is just limited to permanent immigrants and refugees, but there are other long-term visitors who come, and so there's some discussion of the possibility of expanding this to students or those who are on long-term work visas. Goal 5 is to mobilize and sustain support, and this gets back to one of the big challenges I mentioned in the beginning, which is the issue of political commitment, because you have to keep policy, the high-level policy leaders, opinion leaders, and the general public, affected communities all have to be engaged and understand that this is really an important, it's really important to eliminate TB, and it'd be better that if we didn't have TB at all to worry about in the United States. And that is a challenge as you get closer and closer. In fact, my predecessor, Ken Castro, used to quote something called Brown's Law, which is that the closer that you get to the elimination of disease, it's more likely you'll eliminate the program than the disease. What can we potentially do? Well, there are a number of things. One is you have to work with partners, because you can't do this all yourself. And they also, each partner may have the ability to do things you can't do. And so we have many domestic and international partners, and I just listed a few here, such as we have a National TB Controllers Association. We work with state and local health departments, and then professional societies such as American Thoracic Society, Infectious Disease Society of America. And then we have global partners such as WHO and the ministries of health of these different countries. But you really have to be able to make persuasive arguments about the impact and what the benefits are. So showing the effect we've had in reducing morbidity and potentially the cost savings and cost effectiveness of what we do is really important. But the other thing that we've learned about dealing with policymakers is you can quote some of them, you can give them all the statistics and the data, and then at some point their eyes start to gloss over. But what really can have an impact is an individual story. And so some of our partners have been able to engage people who have had MDR-TB and been able to tell a congressman about what it's like to have to go through 2 years of MDR treatment with intravenous drugs, not being able to work, the terrible side effects of some of these drugs, and those things can have a big impact. And so finally, the last thing is you have to be able to track progress. You have to be able to monitor and measure what you're doing and report on what you're doing to your target audiences so they understand that what's really going on and where you're doing well, where you may not be doing so well. And we do this in a number of ways. So one of the things that we have is a National Tuberculosis Indicators Project. And what we've done is we've developed a fairly large number of indicators about various aspects, both outcomes, such as what the case rate is, which is the most important one, the ultimate one, but then certain process measures, such as making sure that completion rates for people with TB disease remain high, looking at measuring various aspects of process and contact investigation and so forth. And so there's a kind of that general monitoring through that program. And then we also need to look at individual states and individual programs and laboratory programs and things like that on an individual basis to see how they're doing. But one of the things that I find, even programs that are really good about developing indicators and generating a lot of data is often they just don't do anything with it. And so you can't just be collecting data. What you really need to do is use those data and when you see that there are problems. So if you see that state X is not having a good completion rate, you need to work with state X and say, how can we improve it? What are the root causes of the problems of why your completion rate is not good? And what are the things that we can help you with to improve your program? So it's really, you have to harness those data and use it to generate improvement. And it's a continuous cycle, reevaluate, keep trying to improve. I'm not going to go through all the indicators, but this just shows you some examples. So some of the indicators in different categories. So as I mentioned, some are process indicators like do people complete treatment or not? And then others are kind of outcomes, which are the TB case rates among all the population and subpopulations. And then the last bullet category here is those related to contact investigation, which is do you find contacts? If you find them, are they fully evaluated? If they have LTBI, do you start them on treatment, and do you complete their LTBI treatment? Because you need to follow through on the whole process to have an impact. So, in conclusion, I think these are the 6 things that we look for in terms of the strategies. We have to maintain our basic TB control functions. If we're going to accelerate the decline toward elimination, we will need to ramp up targeted testing and treatment of latent tuberculosis infection. We really need to promote research so we get new tools, but we also have to make sure that we're implementing the tools that exist in the best way possible. We need to strategically engage in the global TB efforts, make sure we're working to sustain commitment, and then we've got to be able to measure our progress and apply those findings to improve our program as we move forward. So I want to thank you all for your attention. And time for take some questions if people have questions, I guess.
Thank you so much for coming and giving this talk. I just had a quick question about, you stressed a lot, and it's obviously an important issue, of how can we boost other countries' screening programs. What is the CDC working with the WHO about helping other countries kind of boost their screening, given that it's such a, especially for the CDC, such a big impact on us?
So I think there are kind of two aspects to it. One is the programs that are already in place. So we have programs that are about people coming to the U.S., but then there's trying to just improve TB control in a country which is good for the country, but it's good for the U.S. So if there were dramatic improvements in TB control in India, ultimately that would be a benefit to the United States. And that's really a multi-federal agency approach, because not one federal agency can do that. So a really important partner in that is the U.S. Agency for International Development. They provide funding directly to countries, to their ministries of health, to assist in improving their programs. They also provide funding to something called the Global Drug Facility, which is a facility where drugs are purchased at high-quality drugs are purchased at good prices. So this makes it available to countries which otherwise would have problems doing this. And then in terms of what we mainly do is provide technical assistance. So if let's say a country wants to try to improve their TB treatment completion, and perhaps USAID can provide them with some funding to help do that, and then we at CDC would sometimes we have staff stationed in a country, or sometimes we send people from Atlanta, and they provide technical assistance based on our expertise and experience of what are the best ways to do that. So it's kind of, it's a multi-agency approach, and CDC's role is mainly to be the technical expert, and then we have others who are providing funding. There are some areas where CDC does have more of a funding role, and that would be the President's Emergency Plan for AIDS Relief, or PEPFAR. So some of the PEPFAR money, some goes to USAID, but some comes through CDC, and so the global center, some of that money will then go out to countries, and within, even though PEPFAR is mainly directed at HIV, TB is an opportunistic infection, so some of that funding is directed to try to help deal with TB in countries that have very high HIV prevalence. And again, so there's a combination of where CDC may be providing some funding, but we'd also provide people to provide technical assistance to try to help them implement programs. The other thing is that we've, in the research area, for example, our division in clinical trials, 20 years ago, our clinical trials were pretty much all domestic. Now they're mainly international. So we're also helping build capacity to do clinical trials overseas, and so I think there are a number of different ways that we do that.
Hi, I had a question about correlates of immune correlates of reactivation, whether any promising immunologic correlates of reactivation have been identified, and whether there is a plan to put those on a fast track to develop diagnostic testing.
So, every so often I see papers which suggest that, or authors who suggest that maybe they found some combination of cytokines or receptors or something that might be promising. But unfortunately, none of those things has really ever panned out. And, if you look, so the interferon gamma release assays are based on the interferon gamma response. And so other people have tried to look at things like, well, what if we look at a multiple cytokine response? And, there's at least, if you look at individual papers, it may suggest, well, maybe they're a little better, but I have to say, I haven't seen anything that I'm completely convinced. And frequently what you'll see is they may look good in small studies, but then when people try to move them into larger multi-site studies, it just doesn't work. TB, turns out, is really complicated from an immunology standpoint. And just think about the vaccine issue. The one thing about diseases where you're developing vaccines, it's usually the natural infection provides immunity. But for TB, that's not the case. I mean, people are infected, they stay infected for potentially decades, and it can reactivate. And then we also know, because of genotyping, we know of people who have had TB disease. You type the strain, they may be in a very high endemic setting, and then they get TB again, and it turns out it's a different strain. And so they were probably reinfected after they had TB disease and were cured. And that's not that unusual. I mean, it's not terribly common, but it's not that unusual. And so this is, it's really, there's a lot of work that has been done and is ongoing in TB immunology, but unfortunately we don't have a lot of answers to those types of questions.
Yes, for standard guidelines are to screen for TB in patients who are about to be getting immunosuppressive drugs. And then there's sort of lack of standardization of repeated testing, either with a skin test or an IGRA test. Are there formulas or kind of formal guidelines or risk scores for when patients should have repeat testing?
No, I mean, I think the closest thing is probably be similar to what is recommended for HIV, which is that people certainly get tested initially. If you go, the idea of serial and retesting generally would be if it's someone who you think is at risk to get for additional exposure. So if someone was born in the Philippines, lived there, comes over to the United States, and you test them, let's say they're negative. Well, the odds that they're going to get, and we believe that they're truly not infected, the odds that they're going to get re-exposed to TB in the United States, not very high. So generally, we wouldn't, recommend you have to continually test those people. But if for some reason they were in a situation where you think it's likely they might get, maybe they spend a lot of time in homeless shelters, volunteering, or they work in homeless shelters, that might be a different situation, because then there's a potential risk. And in that type of person, I would probably fall back on what's done for HIV, which is probably annual testing.
Hi, Phil. Thank you for a very nice talk. I'm wondering, you showed us data on the incidence of TB in the U.S. over the last 30+ years, a rather dramatic drop since 1992, and then a plateau. And then you also mentioned that there are currently about 13 million latent TB infected individuals in this country. I'm wondering, what are the trends in latent TB infection over that time period?
So that that's a really difficult thing to measure, and we don't. Latent TB is not generally, most states it's not reportable, so we don't actually measure it annually. We don't really. How we measured it and where that number, I will say, is an estimate, and where we got that number from is something called NHANES. So NHANES is the National Health and Nutrition Examination Survey. It's something that CDC does basically to look at the health of the United States. They're looking at all kinds of cholesterol, diabetes, all kinds of things. It's when we can, and we can only do about once a decade, we piggyback onto that study and incorporate, in the past it's just been skin testing, so this is the third time we've done it. This third time that we've done it, we included skin testing and quantiferon. So it's about 5,000 people that are in the sample. The idea is it's to try to mimic what the United States would look like. And so that 5,000 person survey, based on that, the only thing we can compare is skin testing, because we've only done quantiferon once. So if we look at skin testing and account for the confidence intervals, which when you're using 5,000 to represent 300 million, are fairly large. What we see is from the last time that we did it, which was around 2000 to 2011, doesn't look like the LTBI has changed. Now that is not necessarily surprising, because once you have LTBI, the test is going to be positive whether we treat you or not. So even if today we treated every person with LTBI, if we tested them a year from now, they'd still all be positive. So if we're using that as our estimate, it wouldn't change. Even though if we treated everyone, we probably eradicated a large portion of it. It's kind of a difficult thing to measure and to follow trends. The fact that some people get treated and that the test doesn't change, the test result won't change, makes it even more complicated.
Thank you. Any further questions, please come down to the front.